Well, this is just to demonstrate that sometimes or many times nowadays with the third generation stents you can quite comfortably do long stenting. So this is January 2024, patient with CKD, diabetes, hypertension, unstable angina, occluded circumflex, and so he had an occluded circumflex and an LAD which was diffusely diseased all the way down. Okay, so diffuse disease here, all the way down. So this was the end result. The LAD was stented all the way down, and you can see the whole LAD was reconstructed. And the circumflex was also recanalized. This is January 2024. His right coronary artery was also had a narrowing, and which was then fixed with a stent again at the same time. So this was the result in 2024. So he had complex multivessel PCI in January 2024. Now he comes back again with some vague chest pain, occasionally on exertion, and with all these long stents we wanted to make sure that he probably has some restenosis. This is 1 year, 9 months down the line. This is September 2025, and this patient had so just a single shot, the stent here. This creatinine is 2.4, so we are not keen on taking any extra shots. So this is right. Wanted to see the stent, which was fine. It was not a brilliant shot, but you could see that there was no restenosis, and this vessel is fine. So with CKD, and both these vessels are actually quite good. The OM has also positively grown up, and the LAD with all these stents, as you can see, all the stents all the way up here, and the stent here is fine. So this is another 2 ml of dye, and then another 3 ml of dye. And you can also appreciate that the diagonal mouth is also fairly open, and the diastolic frame, we've got a 2.25 millimeter stent here and lots of stents all the way down. So even with CKD, diabetes, a 60-year-old, with these present stents, we are quite justified in doing multi. So this is just one-off for many, but for myself, my experience is most of these patients do well if you have optimized the stents properly. Case depicting total revascularization or reconstruction, and this 65-year-old gentleman had a mid-LAD stent, proximal to mid-LAD stent in 2012. So first angioplasty in 2012, preserved LV function then was okay till 2025, when he had diffuse type of atypical chest pain. Someone ordered a myocardial perfusion scan which showed a large fixed defect in the anterior wall, although the anterior wall seems to be moving here and in echo, and a moderate sized defect in the infralateral wall. He has a left dominant system, so this is a non-dominant artery, and this seems to be filling the LAD, distal LAD here. So we now know that the LAD is occluded, and that fixed defect is probably partially reversible with a normal LV. So this OM is occluded, which would complement his perfusion scan. The LAD is also filling from the isocollaterals here. So it got both isocollaterals something and contralateral collaterals, got diffuse disease here. So the question is how to proceed. A couple of more shots. This distal vessel PDA was diseased in 2012 as well. similar, so the only change is the OM and the LED. The stent seems to be patent, mostly up here and before the diagonal. So we decided to now proceed with our default technique of using a bare Gaia without a contralateral injection in this case. So we proceeded with a Gaia first. Gaia wouldn't go through, so we used parallel wire and went through with a pilot 200. So parallel wire 200, and then it was a lot of work pushing and pulling with a 1 millimeter balloon, and you can see that the arteries now come out. So now the decision is how far to stent, whether to use a DCB or a long stents or just balloon or leave it alone. And just so I thought that in my experience nowadays with the third generation stents, one could get away with long stents. So this is what we did. We reconstructed the whole thing, used a 2 millimeter balloon, and then the first stent here, and then through that another 2.25 stent, and so it looks okay. Now the decision is whether to leave all this alone, but no, we stented this as well in order to totally revascularize this LED. And so now you can see finally that the LED is coming out in a nice way. But we need to do a lot of work, make sure that you don't leave any suboptimal. Either you use an IVUS, or without IVUS you have to use a high pressure balloon at 0.5 to 0.75 millimeter above what you see angiographically. So this is what we've reconstructed the LED, and now the thing is to open this. So again, similar technique, a stent here after using a Gaia, a lot of dissection here, so we used a stent just at the ostium, and so finally a fairly agreeable result. Now I wouldn't have left this alone for it to get severe within the next 2 to 3 years despite the statin. He was already on statin since 2012, but progressed, his disease progressed significantly. He's a non-smoker, no other risk factors. So we decided to just totally reconstruct. So this is one of those cases where a lot of stents, so we used 7 stents here in all, and the final result is acceptable. You can see that the LED is, and this is going to grow. So this is all stented, and one stent here, left dominant system. We didn't want to mess around here at the moment. This was already severely diseased in 2012. So this is the final result of this total reconstruction of the LED. You can see the stents all the way up, and so this is the final result. Let's hope we can continue to have these stents patent.